Hello and welcome to Pitt Street Research. My name is Stuart Roberts and I'm one of the co-founders of our firm. And joining me in Sydney on the afternoon of Tuesday, the 2nd of September 2025 is two very distinguished individuals. On my far right here, Denning Chong, who is the CEO of Singular Health Group, ASX SHG. Next to him, Dr. Jose Pelayo. A great honour to have you here, sir. Dr. Pelayo founded Provider Network Solutions, managed service organisation based in Florida in the United States, about 3.7 million covered lives and growing, as I understand it.
Yeah, we hit 4 million. In January, we'll be hitting 4 million or 4.2 million.
Welcome to Australia.
Thanks so much.
Thanks for coming.
Yes.
Now, why have we got Dr. Pelayo here with us? His company is an investor in Singular Health Group. They've invested in 2 rounds and now are actively exploring the potential of the 3-DICOM technology that Denning and his colleague have achieved. Denning, we'll start with you. Tell us about Singular Healthcare Group.
Singular Healthcare is a imaging technology platform solution, and it was founded back in 2021, or listed in 2021. We're in the business of reducing duplicate imaging costs, so increasing operational efficiency and improving patient outcomes. We've been able to, in PNS, Provider Network Solutions, be able to get a contract with them to do a pilot, which has been announced, and upon that rollout and successful pilot, be able to roll that solution out to the rest of America. So it's an exciting time for us, and it's an inflection time for us, and we're very excited about the future.
Right. So went public on ASX several years ago.
Yes.
The original orientation of the technology was in 3D imaging. And it turns out that the secret sauce that a lot of your potential customers, including PNS, are interested in is the imaging so much as the ability to move pictures around seamlessly between networks.
Absolutely. When we first listed, the business proposition was a virtual reality imaging type model. So you can see images in a VR or XR type scenario. It was a good to have, but not necessary. When you go out to the clinicians, they're all excited, but when it comes time to actually paying for a license, we'll wait. We don't really need it. So it took a few years for us to understand that. And again, when we saw and did all the pitches to hospital networks, came across Dr. Ortiz, actually from Provider Network Solutions, we showed them our technology. Again, they liked it, but there was only one component of our tech that they saw a potential for, and that was our MFTP, our ability to transfer images in a safe and FDA type environment at a quick sort of rate. And he saw the application of that to their workflow system, which incidentally is a workflow system applicable to America in total, and the ability to then reduce the duplicate imaging as a result.
All right. So, Dr. Pelayo, your company has a lot of images coming in and out of the network. My feedback is something like 1/3 of all images are wasted because they can't be transferred easily between managed care provider networks. Is that as serious as the problem gets, or is it worse?
It's worse. Doing a couple of interviews here already, I noticed that the biggest problem is that you don't have the problem here.
Right.
So the most difficult part is having the Australians understand that there is this kind of problem in the US.
Right.
So it's normal, or perhaps more normal, to go to a doctor's office today or a hospital system here, yes, get an x-ray or any other imaging, then go to your primary care or a specialist, and they would just go in there and see the image.
Right.
It doesn't happen in the US.
Right.
It's really disrupted. So most of the time, there's waste because now the patient went to the hospital, had an image done. They go to the PCP 2 or 3 days later, or to a specialist a few days later, and the specialist does not have the access to the image. Right. So once you come to see me as a specialist, I do the exam. Now I want to do the treatment. It's like, well, I just had an x-ray done the other day. And, well, I don't have the x-ray. So I either do one or two things. If I'm lazy, I write you another script for the x-ray, and then you go on your way and you go get another x-ray. If I'm more patient and you're not in severe pain, that you want something done, I'll then ask you to sign a form and go get your x-rays released. And by the time it comes back to me, it's a week later, but you're in pain today.
Right.
And so it causes a disruption of this doctor-patient care.
Right.
So there is a big problem in retrieving the images that were taken outside the doctor's offices for a full evaluation of the clinical picture.
Right. And in Denning's company here, Singular Health, it looks like you've found the solution. You're trialing at the moment in a 1,000 imaging paid trial.
Right.
What was it you saw in this company when you did your evaluation?
Okay. Well, one of the things that was very interesting, they came to Miami, Florida, the first time with their technology. Right. And interestingly enough, their technology was great. Well, it continues to be even better. But who they were selling to was not the right person. Right. They were selling to, at that time, the idea was, let me sell it to the patients. That's not the market. The patients are not the buyer. Right. The MSO, which is called Management Service Organization, or the health plans, are the buyers.
Right.
Those are the ones that have risk. Those are the ones that are paying for duplicate exams.
Right.
And so, for example, PNS has risk that we manage. So every time that there's a duplicate exam, that means that I'm paying twice for that exam, which is medically unnecessary.
Right.
And so I want to remove waste from my system. And the DICOM system allows me to know that there's waste and then how to remove the waste, because we provide the doctors with the opportunity to say, hey, doc, before you're ordering that second image, we have one here for you. Take a look at that image and see what, do you still need to order the other CT scan, which was just done a few days ago or a week ago. Right. And so that's the beauty of, so just removing the duplicates brings savings to my organization, which manages risk.
Right. Let's talk about that organization. You were trained as a chiropractor and practiced for a long time, as you were sharing with me, until an injury.
Right.
And you then focused more on management of clinics.
Right.
You eventually scaled that up into what became Provider Network Solutions.
Correct.
Tell us about your career from back in the chiropractic days till now.
Well,
actually, no, we need to start earlier. You told me that you were a professional baseball player.
Yeah, I was hired. I was drafted to become a professional baseball player.
Which team?
Detroit.
Aha.
And so I didn't last too long because I was injured myself.
Right.
So I went through, I remember the summer, and quickly enough, I was enrolled in school the same August.
Right.
So I was just there for a little trial. But the injury that I had was treated by a chiropractor and not an orthopedic surgeon. So I decided to, listen, I like this non-invasive treatment better than the invasive treatment. So I went to school, became a chiropractor. Had a successful practice, or several of them, for many, many years. And then during the change in healthcare environment in America, we started moving into what at that time was called HMOs, Health Maintenance Organizations. Right. And then
you couldn't open a magazine in the 1990s in America without someone talking about HMOs,
right,
of healthcare.
Right, and then we switched the name because they weren't maintaining anything. So it wasn't Health Maintenance Organization. I thought the name was kind of funny because we weren't maintaining anything.
Right.
And then after that, it became Managed Care. And then now today, it's called Value-Based Care.
Right.
To me, it's the same exact type of medical matter, but today has a sexier name. It's called value-based contracting or value-based care.
Right. And so what all those have in common is you've got insurers with risk. They pass that risk to you, and the aim of the game for you is then to provide the care at a reasonable cost while taking risk away from the insurers. Did I summarize it correctly?
Yeah. It's the insurance in the United States, you're either a Medicaid, which means that socially or economically you can't afford it, so right. The government subsidizes you with the state. Your Medicare, which is 65 and older, you get the benefits of having a federal insurance. You're a commercial, which means that you're working or an employer is paying for your premium, or you're paying yourself.
Right.
Or you're in what we call the Affordable Care Act, which is what we call the Obamacare. Okay. And so those are the four basic categories where one falls. And so and I'm just going to take one for example. So on a Medicare model, the government has a contract with the health plan. The health plan takes risk from that particular contract with the government and now has to manage that risk.
Right.
So they look downstream to primary care physicians as the gatekeepers, and then specialists to perform these services. And what happens is when there's not a management environment around, the primary care physicians, because of how complex it is and how we deal with America health insurance companies, they don't have all the bells and whistles to be able to accurately manage the premium, manage all the conditions that need to happen administratively at their office.
Right.
So they rely on a company like ours, which we're called an MSO, a management service organization. So a management service organization is an organization that does everything that's not clinical to the patient.
Right.
But we manage the contracts with the health plans. We manage the contract with the providers. We help them manage utilization. We help them manage or understand how the claims come in and how they're paid. So we become an administrative arm of a physician's office. So it's not abnormal for us. For example, in Puerto Rico, we manage about 50,000 at-risk lives. That means that the government gave the health plan a contract. The health plan has about 250,000 lives, and we manage 50,000 of those lives.
Right.
At the MSO level. Then we have about 250 or 300 doctors, primary care physicians, that in aggregate manage those 50,000 lives.
Right.
And so our job is to help them become more efficient in managing that population.
Right. Okay. And the more successful you are at that, the better you're able to grow.
The more successful we are, and the better we're able to work with those downstream physicians, we are able to manage the dollar, the clinical aspect of it by the physicians, and the dollar that it costs to manage those physicians more appropriately.
Right. What do you think has been the secret of your success since PNS started?
We've been around for quite a number of years, so we've learned what not to do, right? And we've also learned that without the physicians as our partners, we're going to be outside in a silo by ourselves.
Right.
And so our job is to find solutions, technology, whatever it is that we can provide the providers so that they can do a better job and be clinicians and not have to worry so much about the administrative component of a practice. Right. And that's a big burden, because when you go to school to learn medicine, chiropractic, whatever it is, in your healthcare. Right. But all of a sudden you go out to the real world.
And so you're good with paperwork.
And now you've got paperwork, you've got authorizations, you've got claims, you've got to deal with attorneys. And it's like, well, we didn't learn any of that. Right. So what we try to do is take that off the table for the doctors, so the doctors can practice what they went to school for.
Right. Right. So you've found this technology that Singular has with the ability to markedly reduce your waste in terms of images that you don't want to have to repeat again.
That's correct.
You're now trialing that within the network. What would be a successful outcome for you in that trial?
Well, the numbers are going to show, and this is kind of what the goal is. The numbers are going to show that if we reduce, we know that's about a 15 to 27% waste in the system, depending on the line of business. Medicaid, Medicare, they're all a little bit different. Right. That's kind of the range. So if we're able to reduce 5-10% of that cost, okay, and we've estimated that on average is about a $35 per member per month cost. So $3.50 off. Right. That means $3.50 stays in our fund to either as a profit, right, or to use for other services. Right. So the success is that the more I can save, in this particular case, $3.50, with the more membership I have, it adds to a lot of dollars that are our savings that we can then share with the downstream providers.
Right. So you must be pretty confident. You're not only trialing this product, but you've invested in the company. What motivated that?
Well, I saw the technology. Again, their use case initially was not the right use case.
Right.
Using it through a system like ours, we're using it to reduce waste. Right. And actually not only reduce waste, but also provide better care. And let me just kind of talk about that in a second. Because once we have not only the duplicate image, but when we have access to all the images that patient has, it allows us clinicians to make a better decision how to treat the patient. Right. So if we treat that patient earlier because we got more information, then all of a sudden, that's better quality. Right. We get you to the right care, the right physician, the right specialist at the right time. We have better quality. Right. We start your treatment program faster. And if we do that, supposedly, right, we're going to reduce waste and cost. So that's going to leave more dollars in the fund. So at the end of the day, the patient wins, the health insurance company wins, and we as the management company also win.
Right.
And so by using the technology, it's one tool that we could use not only to reduce the waste, but also to reduce to see a bigger picture of the patient.
Right.
Okay. And I forgot to. I guess I went a little bit with the question. Well, the question was again.
Well, the question was, what motivated the investment? And
Well, it was because I know that if I use it in our world,
yes,
there's going to be more of a surplus. And so, just to explain a little bit, the way that we contract with the health plan. So, and I'm going to use an example. Let's say a health plan receives $1,000 for that member per month from the government. And we have a contract with the health plan at 85% of that premium. So that means $850 are put to the side so that we can manage that fund. Anything that allows us to keep more of that dollar there is a benefit to us.
Right.
And so that was, when I saw that, I said, well, okay, if I can use anything, a tool like 3D decom to reduce my waste, then that means more of those dollars stay in the $850 fund.
Right.
And so I thought it was a really good idea. I invested. The technology was there. Their business model was not appropriate for the U.S. But working with us, they were flexible enough. That's what I think I can say about the singular group. They were flexible enough. They weren't hard-headed. They understood that, it wasn't fun for them. I can tell you from the visit that they were a little disappointed that what they were trying to pitch was not the solution. But the technology did support what we were trying to do. So we just tweaked a little bit and use the technology for what it's really useful to us, which is reduce the duplicate care, duplicate exams, and also now open it up even greater. I don't think that until the pilot is over, we're going to really see a lot more potential. I think the beginning is just, we're going to go with duplicate care. There's enough dollars in waste that we're going to benefit from. So I invested there, and then I invested in the second round. And now I'm asking him to allow me to do a third round, and I'm not waiting for the applause.
Come on, Denning, let Dr. Pelayo invest.
Thank you.
Well, bring it back to you. PNS is just one of many providers of managed service organizations, value-based care. I like that term. I'm going to start talking value-based
care.
America's going to love me next time I come.
That's the buzzword.
Right. There's more than just PNS. There are multiple providers. In PNS case, we just have Texas, Florida, and Puerto Rico. So you can scale like a dream if you've got the data from this trial, and it delivers what Dr. Pelayo was hoping for.
That is our strategy in terms of a national rollout in 2026, pending the results. This pilot. Now, it's important to note this pilot is not a real question whether it's going to succeed or not. The question is the degree of duplication and the ability for us to tweak that system just a little bit more to eke out even more better results. So it's a system that we are working together with. It's a strategy that we're rolling out to other MSOs and other health payers that we are in active conversations with right now to roll out next year. So I know it's something that is very exciting for us and it's a very good prospects.
Right. Denning Chong, Dr. Jose Pelayo, thank you for joining Pitt Street Research and good luck for the next stage of the journey.
Well, thanks so much.
Thank you very much.
Appreciate it.